South Africa, the COVID situation has become almost the front page news for the last 18 odd months, to the extent that so many people have almost become, dare I say, immune, no pun intended, to all the newscasts. But having said that, I think it's very important that we are properly informed. And having listened to our guest speaker on a number of occasions when he's appeared on the news and on radio, he is probably the best informed person I've come across when it comes to it. But the more important thing here, for those of us who tend to maybe panic and fear the worst, he has a very reassuring approach to the pandemic and the things that are happening to lessen it and to create this herd. I nearly said herd mentality. I mean herd immunity.
Not far from the truth.
Not far from the truth. Yeah, and he's eminently well qualified. He is part of the main committee that President Ramaphosa had fielded originally to advise the government on how to move forward with the pandemic. He is the acting vice chancellor of the University of KwaZulu-Natal. I'm not going to go through your bio, Prof, because it is very impressive, and you are an eminently qualified medical person. But I would like my sort of the members of my club to be reassured by you, as well as hearing a little bit about what you have to say. So it gives me great pleasure to introduce to our group, however small it may be, but it will grow, Professor Moshabela. It's over to you, Prof.
Thank you so much, David, much appreciated. And I should thank you again for reaching out and basically making contact and inviting me to come and share my views. And I am very much flattered by your feedback that I tend to present a more optimistic perspective in terms of COVID-19. And I think, you know, it started early for me, and I hope this will also help everyone, all the members, to understand sort of the lens that I have of COVID-19 to this point. So COVID-19, of course, we started hearing about it in January for most of us. And it just so happened that in the first week of February, I had a meeting in Singapore related to some other commission that I am on for the US National Academies. And when we met in Singapore, it was at the time when, in the first week of February, it was at the time when Singapore still had 12 cases. And all the cases that they had were imported. It were people who had traveled to China and came to Singapore. Now, Singapore has experience with the previous SARS epidemic that we had. And because of that, what then happened was that they had an approach that was already established. And because we were there already, we asked them to share with us what they've been doing and how they are thinking of the pandemic. At the time, it was not yet declared a pandemic. And they showed us a 4-step approach that they use, which is now very similar to the 5-step approach that we use in South Africa, where we've got 5 alert levels, but they had 4 alert levels. And basically the first one, it was color-coded. The first one was green, whereby, you know, they don't have any cases in the country. The second one was yellow, where they would have only cases that are imported from outside. The third level was amber, and this is where they start to have local transmission. And the last level was red. This is where they start to have widespread transmission of COVID-19. So you'll remember when we started, there was serious documentation of people that had traveled to this place, people that have traveled to this place, and you know how they got infected and so forth. So Singapore showed us that approach. And on the day that we were leaving, they had detected their first case. It was a Friday. They had detected their first case of local transmission. My goodness, I saw a city transform. Everything changed, and it was almost like in unison. And the idea was that people now had to work from home. They slowed down activities. They were basically screening everywhere. And I looked at how Singapore was responding, and this is the first week of February, and I was like, we are not ready in South Africa. I was like, when this hits us, we're going to have a problem. So I came back and I started having conversations with my colleagues. And the other person who was there was the Dean of Public Health from Columbia University in New York. They started having cases and they were on the phone the whole time. And I was just like, the way the world is prepared to respond to this is not in any way the way that we are prepared in South Africa. So when I came back, I started having conversations in my university to say, let us set up a response team. A response team that's going to monitor what's going on with COVID globally. And this team will then help guide us on how to respond. And we went and I took some of the lessons that I got from Singapore and incorporated them into our model for our university. And so we set up this COVID-19 war room. And I remember at the time, when we launched it in the media, I was interviewed by one radio station and they were saying to me, this was on the 3rd of March when we finally launched it. They were saying to me that, are you guys not overreacting? And, I said to them that, look, based on what I've learned in other parts of the world, it's better to be over-prepared than under-prepared. So if we are overreacting, then it's okay. And people said to us, but you're using war room, that's strong language. Why are you using such aggressive language? And for us, we were like, but this is the concept we have of what we understand about a situation room. When you are faced with a disaster, you need a situation room where you can constantly make sure that you're monitoring and making decisions. And I just realized that a lot of people, they don't get it. Now, that was the 3rd. On the 5th of March, we had our first case. And people now came to us to say, oh, but it's ironic that it's in KwaZulu-Natal. You were the first ones to set up a war room. You were the first ones to be monitoring this. And they now wanted us to provide inputs. And we had basically put together a team of different specialties. Like we've got, in this team, we had infectious disease specialists, we've got virologists, public health medicine specialists, we've got people who are in other kind of parts of medicine who came together to say, let's try and figure out how to prepare ourselves. Now, this was the beginning of the journey for me. I mean, I had dealt with TB before, I had dealt with HIV before, but I had not dealt with COVID-19. But this journey then kind of set us on a path to basically start monitoring COVID-19. You can see in the screen behind me, we're monitoring it using Johns Hopkins website on what was happening in the rest of the world. And this was before it even became too prevalent in Africa. So one of the things that we noticed very early on is this, and we started talking about it. You'll remember the flattening the curve. Let's flatten the curve. Let's flatten the curve. There was a perception that flattening the curve means that you flatten the curve in the early stages so that you can prepare your health system to cope. Then it's all systems go. We were very unhappy with that interpretation by the state and by the public because it did not reconcile with what we understood by the theory of flattening the curve. And the way we had understood it was that it's basically saying that if you are having an epidemic or a pandemic, cases can go up so much, so high, so quickly that your health system will not be able to cope. You can increase your capacity for the health system. That means you raise the dotted line a little bit higher. But chances are very high that if the infection spread, it will exceed the capacity of the health system. And so then flattening the curve then meant this, which meant that you want to do everything you can to prevent transmission of infections so that you do not get to a point where you actually reach the capacity of the state. of the state, of the healthcare system. But if you let go, then you're going to be left with a situation like this one, where now you have cases again exceeding the capacity of the healthcare system. But this was not articulated very clearly, because what was supposed to have happened was that at all times, we needed to keep the spread of infection low. But the impression we had created was that actually we just need to buy time to prepare the health system and we can let go. So this for me began to kind of force me to engage a lot with this theory and begin to think about the different moving pieces. And because my training is in general field, I'm a family physician and I work with public health research, I saw my job as trying to connect the dots, looking at the different moving pieces and try to see how they fit together. Now, this was made clear in South Africa, and I remember the first time this was presented was at a meeting of the minister with Professor Abdul Karim, when the minister was introducing the Ministerial Advisory Committee. And they basically outlined what the staged approach for South Africa is going to be. Many people missed it, but in general, what this was trying to do was to look at 4 areas, and it's informed by the World Health Organization approach to pandemics, that you start with preparedness, and this is largely when you've got no cases or you've got few cases. And that preparedness stage is equivalent to February when we started preparing at our university. And the country was also preparing, but of course the country was only preparing in terms of beds and testing and so forth. They were not preparing other aspects. In fact, my biggest concern about the preparedness of the country was that the country was not preparing South Africans. It was not preparing the population. There were things in the behind the scenes that were happening, but the population was not being prepared. Then there's containment, and that's when you now have all these infections that are happening. But you have to put in place measures to act quickly and contain it so that it doesn't spread. If it becomes widespread, then you put in place mitigation factors. And this is really where you try to limit the negative impact of the pandemic. And then there's recovery. And that's where you basically try to come back to some degree of normality. And so each sort of stage, of course, has activities, things that need to happen in all of those stage 1, 2, 3, 4, 5. And you can see now we are, and you don't, it's not sequential. You come back to these stages again and again, depending on where you are. But if you look at stage 8, we're looking at a stage where you are constantly monitoring, surveilling, but also making sure that there is vaccine program, but you remain vigilant because you might end up with the next wave. And so we go through this kind of cycle. So I'm trying to say this to say that what you normally see, a lot of it is thought out. There are people behind the scenes who are thinking about it. It might not be obvious in terms of people who are not privy to these discussions. You might see, it might look like things are happening at random, it's chaotic, but there is some sort of, what do you call it? There's some sort of logic to the madness that you see, right? So now here, I'm trying to basically take you through the trend over time. And I have to say to you that at every stage of this, like it was constantly overwhelming. Every stage of it, it's overwhelming. Even for those of us who are thinking about how to intervene. If we could, we would have preferred to just have a flat line throughout. We don't want the surges of infections that happen. And we don't want the deaths that come with all of this. We don't want the restrictions that come with, alert levels changes whenever we've got surges. But here, the point is that we started off at the beginning around March with a very aggressive response. And that aggressive response is a reflection of the uncertainty that we have, we expected the worst and we overreacted. And at the time, of course, we felt like it was better to overreact with the hope that if we overreacted, then we can be ready, especially because, as I said, in as much as the Ministry of Health was preparing some beds, was preparing laboratory testing, was monitoring in the borders and all of that, South Africans were not prepared. And I remember at that time, you know, I started speaking more openly about hygiene and precautions before the state actually started speaking about those things. The first time I heard the minister speak about it openly was 3 weeks after we had started doing it. And it was because already we were monitoring the literature, we were monitoring what's happening, and all the things that needed to be in place, we're trying to put them in place as fast as possible. But once the ministry picked up on that, the next thing that we focused on in the first wave was the issue of healthcare workers. We realized that, yes, now you can start preparing the population, you can put them under hard lockdown and eventually release it and kind of may ease it off to make it a level 4, make it a level 3. But the healthcare workers were not prepared. And because the economy was taking a knock and we had to go to alert level 3 at a time when infections are still going up, which didn't make sense. We're supposed to be increasing the alert level as infections were going up. We basically realized that the burden is going to shift to the health services. And we started doing all the surveys and support and training for healthcare workers to prepare them. I mean, I can't tell you the emotions that healthcare workers went through. I remember people having breakdowns because they were just like so afraid of the infections that they're gonna have to face themselves. They were afraid of taking infections to their households. They were afraid of so many things, not knowing what to do because there was no cure. And usually as healthcare workers, we are comfortable when we've got the medication and the gadgets and the things to treat a patient when we get a patient. Now, if you have a person who's really sick and is out of breath, but you can't really give them treatment or cure, it's frustrating. And now you have to, it's traumatic. I mean, for some of us, it was taking us back to the HIV days before the antiretroviral treatment. And so we focused a lot on healthcare workers in that first wave. Now, when the second wave came, we focused a little bit more on the variants, because this is where we announced the beta variant, what we now call the beta variant. And we had not expected that the virus would shift like that. We knew that virus mutate. We knew that it's important to monitor them. And fortunately, in KwaZulu-Natal, we had the genomic surveillance that helped us to pick up the beta variant. But that also accompanied a situation where we were entering December season, and people were saying, well, you told us that you're going to, because of the flattening the curve, you're going to use restrictions, but this will prepare the health system. And when we get to the second wave, you know, it can be free for all because the healthcare system would be prepared. And as I said, based on that theory, it doesn't matter how prepared your healthcare system is. Health systems collapsed in other parts of the world. In Italy, they collapsed because they get overwhelmed when infections go up very quickly. And so that's what we saw in the second wave. And it required then that we again go up to alert level 3 and we institute more aggressive measures. And that's when we also put a lot of pressure on government to get vaccines. Now, long story short, you know, we then got to the third peak. And what was interesting was that the first peak was more prevalent in the Western Cape. The second one started and was more prevalent in the Eastern Cape, but also included KZN. The third one was more prevalent in the Northern Cape, then shifted a lot to Gauteng. And Gauteng bore the brunt of that. And this was driven by Delta, in a different variant. And so we then have to study all these patterns to say what are the drivers of these infections, what are the drivers of the severity of it, what mitigation strategies we have to put in place. And as you can see, in the previous two waves, when the third wave, once we've reached the peak, generally the wave will come down, would come straight down, and we will find relief, and then we'll start releasing the restrictions. But with the third wave, we are faced with the situation where we've got a tail. Instead of the infections coming straight down, they seem to be lingering. And a lot of that is driven by the fact that as we moved from level 4, alert level 4 to alert level 3, there was a lot more social mixing in our society, and infections started to spread again. A lot of the drivers for this has a lot to do with outbreaks, especially outbreaks in schools. And we tried to warn the state to say, we might have to have a rethink about opening schools, because before the third wave, we could see signs that schools were contributing a lot, and it has a lot to do with the Delta variant. So the Delta variant does spread in children, does infect them, and it can even cause death in children or young people. And that's why we needed government to be a lot more cautious. It was not the same situation we saw in the second wave or the first wave. But somehow the Department of Basic Education has been adamant in trying to do catch-up programs for learners because they've lost teaching time, which of course is one of the things that we learned with this pandemic, that you have to acknowledge that there will be challenges, there will be competing interests. We saw it with the tension between health and economy. And then that moved from saying that actually economy is not just macroeconomy, the big things, the industries. No, it's also livelihoods. What effect that has on everyday lives, on people's income and so forth. And then we started talking about lives and livelihoods. And in a way, that livelihood component added a social dimension in terms of how people are not only economically affected by the pandemic, but also socially affected. And I can tell you that this problem of social and economic effects of disease have always been there. We saw them with HIV, but we saw them with TB, but they never really stood out at such a large scale than they did with COVID-19. Firstly, because it happened at such a huge scale. Secondly, because it did not discriminate. It affected everyone, every sector in society. And thirdly, because it happened at such speed, the speed at which it happened, there was no way one would not recognize, which is why we ended up having to have all this social relief interventions. And many of them were initially a consequence of the hard lockdown, but actually, the truth of the matter is that when you think about it throughout the world, the economy was affected everywhere. It wasn't just because of the hard lockdowns that we put in place. It was just because the spread of infection was so aligned with how our economy functions. And I often say this in terms of moving exports and imports throughout travel throughout the world. We carry infections, we carry viruses and spread. So when you limit that, you actually paralyze the economy as a whole. So level 5 lockdown, level 3 lockdown, level 2 lockdown, your economy gets infected. When you start to close borders and you try to contain infections, you isolate yourself. But also what we noticed was that it was affecting people, not just movement of people globally, but just relationships between people, the way we related together. We are no longer able to spend time together. And that impact socially, psychologically was quite significant. And I think that it's probably more significant than we realize and more significant than we acknowledge. And I think that we are still going to see the effects of this with time, and we must not underestimate it, because part of the problems that we are seeing currently is the mental health effects of this. And so, yes, there are social and economic effects at a large scale, but at the individual, at the familial, at the community level, in the workplace, these relationships have been tampered with a lot. And I don't think that even if things were to get better tomorrow, that we will just go back to normal. We're going to have to figure out exactly how to mend those relationships going forward. This is my second last slide, that just to share now that once we've gone through all these waves, and we have learned so many lessons, we then had to grapple with this idea of variants on the one hand that are constantly shifting the way we understand the pandemic, but also shifting the way that we respond to the pandemic. And as I said that, after the second wave, we started to be really serious about vaccines. And South Africa, of course, bought those vaccines from India, the 1 million doses. And when we realized how serious the beta variant was and how resistant it was to the Oxford AstraZeneca vaccine, the country decided to let go of it. Some of us, of course, protested. We felt like it was better to have some vaccines at hand than not have any vaccines, because then that was going to delay the launch of our vaccine program. And of course, at the time we did not have the evidence to support strongly why we needed to keep AstraZeneca. In fact, the evidence that we had was suggesting that, it may not be in our best interest to keep it. But in retrospect, in hindsight, we know that the Delta variant responds well to AstraZeneca. In fact, the UK uses AstraZeneca and Pfizer, and other places use AstraZeneca, and it's responding really well. So it's unfortunate that when you're dealing with the pandemic, you end up having to make decisions with very little information in front of you. And the decisions that you make oftentimes have major implications and ramifications. And, in South Africa, of course, we prefer to have certainty. In South Africa, if you don't have certainty, it's not good enough. People are not really forgiving of decisions that are made with partial information. And that's why, they will take you to court, they will do a lot of things. And it has resulted in a situation where even our government is not able to respond proactively. Because if they respond proactively and they make the wrong decisions, they will pay for it. And so the way the state machinery works is very reactive, because people want to wait until they are so sure of what they're making, the decision that they're making, only then that they act. But if you do that with the pandemic, you're basically allowing it to lead you. You're not going to get ahead of it. You're going to constantly be chasing it. And so that's what we saw. And that's what we continue to see at the moment. And so it takes a lot of a kind of leadership to lead during a crisis like this. A different kind of decision-making process. A lot of it, I find that it is very intuitive. A lot of the analysis that I give, a lot of the advice that I give, you find that part of it is science, another part of it is logic, and another part of it is intuition. And it's not easy when you are in a policy forum to explain your intuition. You have to basically back it up. And sometimes you may not trust your intuition. But for me, fortunately, I started early with the pandemic at a time when it was not here. And so I was not afraid. A lot of people got involved in it out of when they were reacting and already reacting out of anxiety and fear. But we were already on top of it and we felt comfortable. We were doing modeling, we were doing all kinds of things, the literature and surveilling it. And the longer you are in it, it's almost like you start to kind of even sense the direction in which things are going. And so as much as that does not count when it comes to the boardroom where decisions are made, it helps for us to be able to say that, to raise questions, to raise things that people need to think about, to begin to expose the blind spots that might exist in the decision-making process. So this is basically how I have felt in the way that we've been navigating the waves of surges of infections in the way that we've been navigating variants, navigating vaccines. We are, of course, at a point now where we've got the vaccines. We are coming out of the third wave slowly. We have opened vaccines to all adults. We've got good vaccines in the form of Johnson & Johnson and Pfizer. We've got Sinopharm that has been given emergency use approval. We also have AstraZeneca that's been approved for use in South Africa, even though we are not using these two vaccines. But we've got enough doses. We've got enough doses for a large part of our population in terms of 75% of the adult population 18 and above. Very soon, I suspect that we're going to start talking about how to reduce that age limit down to 12. So try and get the group between 12 and 18 as well. And that might have consequence in terms of ordering more vaccines. But right now, we're still dealing with trying to optimize the different groups that we are giving vaccines to currently, and dealing with any hesitancy or doubt and so forth. But it's a complex system of navigating all these different pieces when they come together. Let me finish off with this slide, where I did some work with the German government to try and understand where they can put in investments in South Africa. And one of the areas we're looking at was the biggest gap, in my experience, the biggest gap in the whole pandemic response has been, one, public health communication. And our government and many others, they've tried to communicate what's going on. But as I said, I constantly felt like the population was not prepared. Health workers were not prepared. This one was not prepared. This one was not prepared. So I felt like there's a better way we could have done that. That's one part. The second part is this. It's the fact that we didn't really prepare ourselves in terms of how we could leverage our own manufacturing in South Africa to respond. Ultimately, we ended up with Aspen and the fill and finish of Johnson & Johnson. And now, you know, we've got the Pfizer BioNTech also having potentially some sort of fill and finish for their vaccine with BioVac. So we have made some progress, but what we found when we did this analysis of the value chain of vaccine manufacturing in South Africa was that we are good with the upstream, where I've got a 1. We are good with that research and development. We can produce products. We are also good with the phase 3 clinical trials like we did. We did trials here for Johnson & Johnson. We did trials here for Novavax. We did some trial here, some studies here for Pfizer. We are good with that part, including commercialized manufacturing, as Aspen is doing, as BioVac is doing. We've got that capacity. Where we are lacking is the middle part, number 2. And this is a sensitive part. And this is where you would have had in the news of the company in Baltimore that had to shut down because of the active pharmaceutical ingredients that needed to be changed because they were contaminated, or shall we say, spoiled. And we ended up having to import APIs from Germany in Europe to try and complete that process of fill and finish at Johnson & Johnson in the Eastern Cape. So this is where we are lacking. We don't have the capacity to manufacture the active pharmaceutical ingredient. And if, you know, the question is ever asked to say, why is it that South Africa did not manufacture this vaccine? We had prototypes, but we could not take them through the full value chain of manufacturing because this piece was missing. And this is where we have to build the infrastructure. We have to get the training to make sure that this part is going to be filled. And a lot of us are now sort of engaged in conversations around how to strengthen this and how to ensure that we can do the full value chain, not just for South Africa, but for sub-Saharan Africa. Let me pause here and thank you for your time listening, and I can hand over back to you, David.
Thank you, Prof. That was fascinating, absolutely fascinating. And I'm quite sure that there are going to be questions that are going to be asked now. So what I'm going to ask you to do, please, is if you have a question for the professor, you raise your hand, please, in an electronic way, and I will do my best to manage the questions. Maybe I can kick off with possibly the more difficult question for you, Mosa, and that is that if you were to put on your prophetic cap, which I know is very unfair, so I'm not expecting you to be accurate in your assessment, but let's move forward to December. Where do you think South Africa will be around about the beginning of December? It's got nothing to do with Christmas holidays. I'm just interested to know where you think we will be in terms of levels, etc., etc.
Yeah, no, it's a very important question, I think. So far, I would say that there are two things that are going to play an important role there, right? One is that it's going to depend a lot on the vaccination. It's so important to fast track the vaccination now. Vaccinate as many people as we can. I am hoping that by December, we would have vaccinated 20 million South Africans. Secretly, I'm hoping that, and that's me being completely realistic, and that's the minimum that I think is going to be important. And the reason for that is because when you look throughout the world, you start to see the impact of vaccination when it starts to hit 50%. If it doesn't hit 50%, you don't get enough impact. I mean, New Zealand is 20%. Australia was at 30%. They had to shut down. But in places where you had at least 50%, then you realize that they are able to maintain a large degree of normality when they've got a surge in infections. We are already more than 10 million people vaccinated in South Africa. If we've opened to 18 plus, I'm hoping that we can certainly be able to double that in the next month of September, if not in October. And if we get to 20 million, say by October, those people would probably have full immunity by the time we get to December. And that's going to be really protective. And then we hope that another proportion of people can be partially immunized. I don't want to depend a lot on the partial immunization, because in as much as it gives some protection, it doesn't give optimum protection. So that's going to be important. The second thing that's going to affect us is going to be variants. We have to keep monitoring, doing genomic surveillance to see where the variants are going to go. Generally, we say that when the variants evolve, they evolve to become more transmissible, but to be less severe. And as you can see, the Delta variant is more transmissible than the Beta variant. But the Beta variant is the one that is most resistant to vaccines. If you can win with vaccines with Beta variant, you can win with Delta variant. However, you're going to have more burden on your health system with Delta variant. We are seeing now that even the mortality rate is lower with the third wave compared to the second wave. And we are hoping that that means that on a large scale, the severity of the Delta variant is less than, the impact is less than that of the Beta variant. So if that logic holds, then we could hope for, if there's any evolution, that even if a virus is more transmissible, it's going to be less virulent. It's going to cause less negative impact. And if that is the case, and it happens with a large-scale immunization, then we can see the benefits that people are seeing in other parts of the world, where you have a surge of infections, but the mortality stays low. Especially if you've immunized most of the people that are at risk. One of the group that was bothering me was the group between 18 and 34 that has comorbidities, but did not qualify for vaccination. And now that we can vaccinate that group, I'm hoping that all the people with comorbidities, even in that age group, can be vaccinated. If we can vaccinate most of the people that have risks, either by age or by comorbidity, then even if we have a surge in infections, we can mitigate it better. And that's why you hear people saying, oh, you might not be able to achieve herd immunity, because herd immunity means that, yes, you reach a large coverage of 70, 80% of your population. But not only that, once you've hit the coverage of 80%, you must see the disruption in the spread of infection. If you don't see the disruption in the spread of infection, then you don't have herd immunity. You have large coverage, but there's a difference between large coverage and actual herd immunity, where you're able to disrupt spread. We are seeing the evidence now that the vaccines are helping us in terms of reducing the spread. We were saying that reducing the transmission. We were saying that, we know the vaccines are going to protect you from severe disease, they will protect you from death, but we were not sure whether they will reduce transmission. Now we are seeing that. It's not zero, and it's not going to be zero, but it will be lower than when people are not vaccinated. Which is why then it becomes important for us to see this as, one, prepare your body to respond better, but secondly, make an effort to break transmission. Every individual has to try to achieve that, to make sure that they're immunized so that their body can respond better, especially people who are at risk of severe disease, but also we have to stay committed to this effort of breaking transmission. If you can remember the theory of the flattening the curve, a lot of it is about preventing spread of infection between people, those things that we do as individuals. So I'm thinking that we've got vaccines, we've got variants that we have to pay attention to. And if we can monitor those two and maximize our vaccination, keep track of our variants, and know what they respond to, we are going to respond better to the fourth or the fifth wave, whatever the case. And we are seeing that evidence in other parts of the world. That's what makes us optimistic, that a surge of infections in December in a largely immunized population, it's way much better than when you have very few people vaccinated. And the first, the second, and the third wave found us with no vaccination. Whatever variant we have, that immune system that is there, as long as it's a SARS-CoV-2, that immune system that is there will play a role in protecting us to some degree. It's not going to be zero effect. And so even this talks about, well, the immune system may not last long, say 8 months or 12 years, we might need a booster. Sure, we can continue to look into it. But I do think that right now we have the advantage that anyone who's immunized will offer and will confer some protection. Protection for themselves, but also protection in terms of spread from one person to the next. So, David, that's what I would say about December, to say that if you want a sort of a better experience or better prospect for December, right now we have to focus on making sure that people are getting vaccinated. We keep track of the variants. We are going to get out of the third wave. That, for me right now, I keep saying to people that, okay, don't worry so much about the fourth wave, focus on getting out of the third wave. But I agree with you that we have to start preparing ourselves to prevent negative impact with any future waves that we might have. That kind of thinking will help us to work collectively to kind of protect our society, protect our economy, protect our country from the negative impacts of any surge of infections in the future. Let me pause there.
Thank you, Mosa. I've got a number of people who are writing in questions, which I'll deal with in a second. But Angela, you've been very, very patient. Do you want to ask your question now? Because your hand has been up for a while now. Angela?
Well, I had a similar question to you about that fourth wave in December. So I'll leave that. But another question that I had is that tail that you see at the end of this third wave, Do you think that it might be that because people have now been vaccinated, they now think that they're safe and they're now doing things that they shouldn't, even though their immunity is not quite up yet? You know, they don't see that they need at least 60 days, let's say, from vaccine to really be immune. And people are actually now going out and mixing and doing things they shouldn't.
Yeah, it's a good question. I have to say that I think, so if you look at the age groups that are vaccinated, amongst people who are 60 and above, we are at about 60% vaccinated. People who are 50 to 59, we are at about 40% vaccinated. The 35 to 49, we are at about between 25 and 30% vaccinated. And the recent group that's just joined is a small proportion. It's still at less than 5%. So a lot of the people that have been vaccinated are the people that are unlikely to take risks on a broad spectrum. They are unlikely to take risks. In fact, a lot of the risks that we see, they come from younger generations. There might be some people in the 35 to 49 group that may have taken some risks, but I think it's a small population, and they didn't take the risk because they feel that they're being irresponsible. I think they took risks because they did not understand that after you're vaccinated, you have to wait at least 1 month with J&J. If it's Pfizer, you need to wait 2 weeks after your second dose until you're fully vaccinated. And they also didn't understand why it's still important to follow prevention and precaution measures. So I think if there's any risk that they took in that group, because that age group is concerned about people dying. They've seen their peers, their friends who got affected negatively by infections. So I would say that it may be more poor understanding. The other thing I think that we saw there was fatigue of people just, level 4. There's a lot that's happening that people make people take risks. And in a way, because these restrictions have affected people, the mental health of a lot of people, then it made sense that they would want to go out. They would want to go back to those activities that help them cope with stress, cope with pressures of life, and so forth. So I would say that if anyone is going to take risks, it might be some sort of calculated risk, because they are weighing risks and benefits, especially in terms of well-being. The last thing that I would say in terms of taking risks, I think it's when people don't really have a choice. People have businesses to run, people have to go and really hustle because they need things done. And sitting down means that, the socioeconomic situation gets bad. So I don't necessarily see it as irresponsible. The one thing that has contributed to that tale that I'm most concerned about is schools, because I feel like that's the one that could have been managed better. And a lot of reports come from outbreaks in schools. If you look at the numbers and the different reports, that's the major contributing factor. But I agree that it had to do with us coming out of level 4 and moving into level 3. And unfortunately, one of the things that I don't like to talk about, but I should mention, is the fact that we've also politicized the pandemic and the vaccinations and the response to the pandemic. So a lot of people who are aligned to certain political views and perspectives, they would react depending on the political tensions. And so we saw a situation where people feel like their autonomy is being violated, their rights are being violated. And that is the reality we live in. And so they lash out because they feel like there's oppression and so forth. And they don't really understand that you could look at the pandemic separate from the politics and judge it independent of the politics. And for me, I see myself as an independent analyst. I'm not really constrained by any allegiance to government or anything. I'm an academic. So if there's something that doesn't make sense, I will call it out, from the perspective of policy decisions or government. And And what I normally do, even as David was saying, when I speak publicly, I try to identify those gaps and problems and advise government. I may not have a seat at the table, but when I speak publicly, I offer advice and guidance on the kind of things that need to happen. So I think that tale really, for me, it's explained largely by coming out of the both level 4 to level 3. So there was a little bit more social mixing, but in terms of specific categories or sectors, it was really largely from the